Henderson. Dr. Henderson is an associate professor in ophthalmology and neurology and the Frank B. Walsh Professor of Neuro-Ophthalmology at the Wilmer Eye Institute at Johns Hopkins University School of Medicine in Baltimore. She's also the chief of the Division of Neuro-Ophthalmology at Wilmer. She attended medical school at Emory University, and then she completed her residency in ophthalmology at the Medical College of Georgia and a fellowship in neuro-ophthalmology at the Bascom-Palmer Eye Institute. In addition to her work as a clinician, she's involved in clinical and translational research with a focus on optic neuropathies. She's published over 45 peer-reviewed publications, as well as a book entitled Controversies in Neuro-Ophthalmic Management. She also has an interest in education, serving as the Neuro-Ophthalmology Fellowship Director and Associate Ophthalmology Residency Program Director at Wilmer. She holds leadership positions on education-related committees in the American Academy of Ophthalmology and the North American Neuro-Ophthalmology Society, and she's received multiple education-related and leadership development awards. So with that, Dr. Henderson, thank you so much for joining us, and I will hand it over to you.
Thank you so much, Allie, and thanks to the whole HOVC team here for the opportunity to talk to all of you guys tonight. I am going to get my screen shared here. So I'm so impressed with what the team has put together here as far as this program in such a short period of time, and I feel very honored to be joining the impressive group of speakers that you guys have had. So the way I was going to sort of structure this evening was to talk just a few minutes about sort of my journey to neuro-ophthalmology in case anyone is interested. And then just talk for a couple minutes about what neuro-ophthalmology is. I know it's not very prominent in a lot of medical school curricula, so it might be worth a few minutes on what neuro-ophthalmology is. And then I thought about doing a day in the life of, which is kind of what the team had suggested to me might be helpful for you guys. But we're going to do a variation of that, which is more like a week in the life of, because I think one thing that's cool about my career is none of the days are really the same, and I get to do a lot of different things, which I really enjoy. So that's kind of how we'll structure it. I will try to keep this to 30 minutes so that we can have plenty of time for discussion at the end. So starting on my journey to neuro-ophthalmology, I guess I decided to go to med school when I was pretty young, like in high school. I took AP Bio and I said, well, I kind of like this. Maybe I'll go to medical school. And at this point in my career, I'm not sure that there's really any link between AP Bio and medical school. But at that point in time, it kind of made sense. And so that's what started my trajectory toward medicine. I went to Emory, where I was a neuroscience major and obviously was pre-med. And so when I went to medical school, I decided to stay at Emory for med school, and I'd done this neuroscience degree, so I thought maybe I would go into neurology, but I didn't really know. I didn't know a whole lot about medicine, and so I just said I'd figure it out during med school. And then during my first year as a medical student, we actually had a lecture in one of our big lecture hall lectures from one of the neuro-ophthalmologists at Emory, who's Dr. Valerie Buse, and she's like a pretty dynamic speaker, and so I'm sure that had a lot to do with it, but she gave this great talk on eye movements and how you could localize lesions using eye movements. And I think at that point, I was just really impressed with how much you could do just from movements of the eyes and how many different conditions you could diagnose and localize. And it all seemed pretty exciting. And so I already had a neurology mentor, so he had offered to introduce me to any faculty member I wanted to meet. And so I asked him if he could introduce me to her and her group, which he did. And they were nice enough to let me tag along on some research projects early in med school. And then to join their team for what was called the discovery phase at Emory, which was like a 5-month research block that we had built into the curriculum. And so I spent those 5 months doing research with them, doing a lot of writing with them and spending some time in clinic. And so by the end of that, it was pretty clear that I was headed toward neuro-ophthalmology. So neuro-ophthalmology is maybe a little bit different from many subspecialties, because you can actually go toward neuro-ophthalmology as an ophthalmologist or as a neurologist. So this was actually sort of my decision point. Was I going to do ophthalmology residency and then become a neuro-ophthalmologist, or was I going to go the neurology route? And so for a few reasons, and I think ones that I would say are pretty good. I decided to go the ophthalmology route. Ophthalmology residencies actually do have a fair amount of neuro-ophthalmology in them, whereas neurology residencies don't tend to have as much. And also in ophthalmology, if you're interested in surgery, which I thought I might be at the time, you do get to do the surgical training, which is pretty cool. So I did my ophthalmology residency and applied for neuro-ophthalmology fellowships, and now we have a neuro-ophthalmology fellowship match, but we didn't at that point in time, so it was just sort of a free-for-all. And so I managed to convince the team at Bascom Palmer that they would like to train me, and so they allowed me to come down there and do my fellowship with them. And then after that, I came to Wilmer. So Wilmer was really my first faculty position, my only faculty position. And I didn't really have any connections to Wilmer. You know, I selected Wilmer based on the job. I mean, I applied to a few academic programs. I really wanted to be like a pure academic neuro-ophthalmologist. And so there are sort of a limited number of places where you can do that. And when I visited the team at Wilmer, I thought, you know, this was a place where hopefully I could contribute something to neuro-ophthalmology and have an enjoyable, fulfilling career. So this is year 8 for me here at Wilmer. So 8 years out of fellowship, 8 years at Wilmer. And so now I'll tell you a little bit more about what neuro-ophthalmology is and what I do in neuro-ophthalmology. So a couple things I like to highlight in terms of patient care in neuro-ophthalmology. I think issue number 1 is we're really taking care of patients who, for the most part, have systemic disease that are affecting their visual pathways. And so it's pretty different from some other fields in ophthalmology where you might really be focused on, you know, the lens or the cornea or like one part of the eye. We're really more focused on diseases that are either affecting the central nervous system or affecting the whole patient and happen to involve their visual pathways. I also like to mention, because I think it's sort of unique in medicine, that we get to see patients of all ages. So we take care of children who have neuro-ophthalmic problems. There are actually a lot of systemic conditions that can affect children from the neuro-ophthalmology standpoint. We'll actually see a case of that later on in this presentation. And certainly young people, young adults, again, because of the diseases we treat, things like MS, autoimmune disease, pseudotumor cerebri, we see a large cohort of young women. And then, like many ophthalmologists, we do also see older patients. But I think we really get a lot of variety, which is pretty fun. Along the lines of variety, because we're treating systemic disease, we also get to collaborate with lots of cool multidisciplinary teams. We work very closely, like daily, with neurosurgery, with neurology, with endocrinology, with pulmonology, with all sorts of subspecialties. So if you like collaborating with other brilliant physicians, it's pretty nice. In terms of research, we'll talk a little bit more about what I specifically do in a few minutes, but I think in terms of broadly looking at research in neuro-ophthalmology, if you're interested in basic or translational science work, there's so much work to be done because we still have so many diseases that affect the central nervous system that either don't have any treatment at all or have very limited treatments. And so if basic science interests you, that there's plenty to do. In terms of clinical research, we are sort of rare disease specialists. Even bread and butter neuro-ophthalmology tends to be more rare diseases. And so often our clinical research involves multi-center collaborations and even, you know, national and international collaborations. So that's I think fun. So if you like collaborating with other people, it's a great field for that. And for whatever reason, the neuro-ophthalmology personality, I suppose, tends to lend itself toward being interested in education and teaching. And so I think I really never met a neuro-ophthalmologist who didn't love education and teaching. So we all spend a lot of time doing that. All right, so now I'm going to do my week in the life of, and hopefully I can keep this from being too disorganized and try to kind of take you through basically what a week, at least in my life, looks like as a neuro-ophthalmologist. So I'm just going to go day by day. Clearly, you know, the exact days don't matter, but I think this allows me to cover everything that, you know, that I do on a regular basis in some sort of organized fashion. So on Mondays, I do a procedure clinic. And actually what I do in my procedure clinic is botulinum toxin. So this is like Botox, Xeomin, things like that. So I thought I'd just go through a case to talk about, my typical Botox patient and how this goes, or could be any kind of botulinum toxin patient. So here's a patient, was one of my early Botox patients shortly after I came to Wilmer. She's a 59-year-old woman, and she came in for the first time saying she'd had 8 years of left-sided facial spasms, and they've been progressively worsening to the point that now she just goes to work and she comes home. She was very social before all this happened, but she's become really self-conscious. And when we look at her on exam, she really has these severe left-sided facial spasms. So the right side of her face looks completely normal, but the left side is, her eye is closing, her brow is going down, her mouth is pulling up, and she has all this asymmetry and is very uncomfortable about it. And so at this point, this looks like what we call a hemifacial spasm. And so usually when a patient has a hemifacial spasm, it's because something is irritating the facial nerve. And so the first thing to do is to get an MRI, because you want to make sure that's not a tumor or something really concerning irritating the facial nerve. And so this is like a sagittal, like a high resolution sagittal T1 from her MRI. And you can actually see the blood vessels and the nerves. So we got cranial nerve 7 here. We got it labeled. And there was a little blood vessel here, which was sort of contacting the nerve there and irritating it. And in fact, that's usually what causes a hemifacial spasm, is a blood vessel that's gotten a little tortuous and is sort of pressing on the nerve. And so in her case, that's what was going on. So fortunately, this is not, something life-threatening, but it is something that's really affecting her life. And so we talked to her about the options. And, option 1 is we do the botulinum toxin. It's a good treatment because it works really well. But the downside is it's not a cure, it's the treatment. And so these patients have to come back about on average every 3 months to get their botulinum toxin treatment. We also talked to her about the other option, which is something called a microvascular decompression, where essentially the neurosurgeon, they'd describe it better than this, but they go in there and shove a sponge between the facial nerve and the vessel and can stop the spasm. And clearly this is great because it's a cure. But the downside, of course, is that it's brain surgery that involves manipulating blood vessels. So there are some risks involved with that. And so she was a little uncomfortable with all those risks and said, well, let's go ahead and try the injections. And after she got her first set of injections, the first set, she came back and she said, oh man, you've given me my life back. I'm symmetric again. I can go do all of my social activities. This is just great. And she's, in fact, she has continued to come back to Hopkins for the last 6 years and get her injections every 3 months or so, and is really very happy with this. And, I think she's sort of a typical case of a hemifacial spasm, and we also treat blepharospasm patients. And the reason I like doing this is, number one, we do treat a lot of neuro-ophthalmic disease that doesn't have a good treatment or that doesn't have a cure, but we can really make these patients a lot better. And even though they do require serial treatments, they're often very, very happy with the results. And, I think the other reason I really like my botulinum toxin clinic is the fact that they need serial treatments, because I get to know them all really well. And so it sort of gives you that aspect of ophthalmology that you might see in other ophthalmology practices, like retina doctors who do injections all the time, get to know those patients. This is sort of the neuro-ophthalmology version of that. So there's my Monday morning, my botulinum toxin clinic. So on Monday afternoon, I go down and I staff the resident clinic, and we won't spend too much time on this, but essentially this is a mix of all the things I like to do, right? I get to work with the residents, and I get to work with them through their residency here in the resident clinic. I get to do lots of neuro-ophthalmology, because very quickly after I started staffing on a certain afternoon, that day turned into a neuro-ophthalmology day, sort of inadvertently. But I also get to see other ophthalmology patients. So this is like the half a day a week that I get to do a little bit of comprehensive ophthalmology as well. I'm also available, to staff inpatient consults, ED consults, and actually that's not just on Monday afternoon. That's something that we as neuro-ophthalmologists are always available to do for our residents who are really holding down the fort. So that's my Monday. As far as Tuesday, so on Tuesday I don't have clinic. I call it an academic day. Some people call these administrative days. And even though I do a lot of administrative work, I like to think of it as an academic day because, this is my day to really contribute to neuro-ophthalmology, contribute to education, and potentially build my own career and hopefully the careers of other people during this time. So I thought I'd take this day to talk a little bit about the research that I do. I think one thing that I perhaps is a weakness of mine is that you often hear good advice to narrow your research focus, and that's probably a really good thing to do. I'm interested in a lot of things, and I haven't really been successful with narrowing my research focus too much, and I'm okay with that right now, but maybe one day I will. So really, my research involves all these areas that I've listed here. I do collaborate with a lab looking at treatments for optic neuropathy, and specifically using animal models of an optic neuropathy called NAION, or non-arteritic anterior ischemic optic neuropathy. I don't run my own lab, but this is a lab where there's a lot of rodent work done looking at treatments for NAION, and then sort of my role here is to collaborate on the translational portion of the research. So when the treatments are looking good in the rodent models, then some of my colleagues and I, who are clinicians, collaborate on the translational work in primate models to sort of the idea being that this could be the bridge to clinical trials. So it's a work in progress, but I think it is really interesting to collaborate with basic researchers, and so I do some of that. I also do some work on high value care, and Allie, who introduced me here, is one of the experts on this because she just had a paper published that we worked on together, focused on high value care for neuroimaging for our subset of patients, of course, with the goal that this could one day be applied to larger subsets of patients. As I mentioned, because we focus on rare disease, a lot of our analyses really have to be sort of larger set analyses, so larger databases and so-called big data studies. Again, I think we have some people on this call who have worked on some of these with me, and hopefully this will continue to grow in the future in terms of using multiple centers and large databases to get answers that we really otherwise can't get for neuro-ophthalmic questions. We're doing some work on racial and socioeconomic disparities in neuro-ophthalmic conditions. As of right now, that work is mostly focused on our databases here at Hopkins, but hopefully that can be expanded to larger groups in the future as well. And as I mentioned earlier, I participate in a lot of multi-center collaborations, sort of depending on the project. One of my favorite is an optic neuritis consortium, which is actually led by the researchers at Mayo, Dr. John Chen, and several other researchers up there who really have an international consortium evaluating optic neuritis. And again, because it's rare disease, it really takes these international consortia to develop changes in treatment and to develop changes in the way that we manage patients. And in fact, in the last 5 years or so, largely due to the work of the Mayo investigators and their consortium, it really has changed the way that we approach and treat optic neuritis in many patients. I'm also participating in some other multi-center collaborations with various institutions that you see here. All right, so I sort of debated whether I should put any mention of meetings in here, but I thought I would, only because I think, we're all very busy during the day. You will be when you're practicing, and you certainly are now. And, I think one thing that you really can miss out on development opportunities is if, you think I only work between 8 and 5. And sometimes it's worth collaborating with other individuals at your own institution, and certainly other individuals around the country and around the world who may be in very different time zones, sort of outside of the normal working day. So I only mention this to say that, it's not that every Tuesday evening I have a meeting or that I don't have meetings other evenings, but I think working with colleagues sort of outside of the regular work hours, if you will, can be very, very rewarding. And it's really the way that we're able to provide the best care to our patients and also to develop sort of bigger programs around the country and around the world. All right, so now we're to real neuro-ophthalmology clinic. So on Wednesday, I have a full day, real complete neuro-ophthalmology clinic in one of the satellite locations. Rather than talk about what a clinic's like, I thought we'd do a case that's sort of bread and butter neuro-ophthalmology, something that would come in probably once a week. So this is a 31-year-old woman who has a headache, transient visual obscurations, and whooshing in her ears. Her acuity is 20/20 in the right and the left eye. She has no RAPD, full fields, full motility, and she's a little bit overweight. And so here's what her optic nerves look like. So hopefully we can all agree that these are not normal. You can see she has all this obscuration of the vessels, not only around the nerve, but even on the nerve. She has blurred margins. I mean, I think blurred's an understatement here. There are like no visible margins of the optic nerve. And even though this is not a stereo photo, it really looks like this nerve is elevated, right? She did a visual field in our clinic. And so in case people aren't familiar with visual fields, this is what we're going to look at. This is what she saw with the right eye. This is what she saw with the left eye. And what's striking about this is this visual field looks pretty good. So we have physiologic blind spots here. That's where the optic nerve inserts into the retina. And so she misses a few spots around the blind spot, a little enlargement of the blind spot. But that's just because, she has swelling of the nerve. So the photoreceptors are sort of lifted up around the optic nerve. But other than that, the fields look really good. And and her OCT images, or optical coherence tomography images, the retinal nerve fiber layer thickness, normal would be like here in the green. Hers is like way up here. So this is swelling of the nerve. This corroborates what we already knew. And this is the ganglion cell segmentation. So these are the cell bodies that give off the axons that make up the optic nerve. And they're really preserved. They look good. They're all green, right? And so that goes along with what we saw. Her visual function is preserved. She just has really swollen optic nerves. And so in this patient with bilateral optic nerve swelling with preserved vision, this is really the clinical presentation of papilledema, which is optic nerve swelling specifically secondary to high intracranial pressure. And so I'm sure everyone on the call knows that high intracranial pressure is not a good thing, and we have to rule out concerning structural lesions that might be contributing to that. So things like tumors, things like blood clots, meningitis. And if all of those things are ruled out, then we might consider whether this could be a primary or a secondary pseudotumor cerebri syndrome. So she got her MRI, which was done urgently because we wanted to make sure she didn't have some terrible structural lesion. And fortunately, she didn't. No tumors, no blood clots, but I did want to point out a few findings on the MRI that are pertinent. Here you can see the sella, and normally the pituitary gland, which is this sort of bright structure over here, would be taking up pretty much all of the sella, but it's really pushed over to the side, and this is what we would call a partially empty sella, and that makes us think maybe her intracranial pressure is high, and we sort of already know that because we saw her optic nerves. But if you saw this on a scan, you might think maybe the pressure is high. The other thing we can see here on the T2 is that the back of her globes are flattened, like they're sitting on a table. That can also be seen with high pressure. And then on her MR venogram, which we got to look for a venous sinus thrombosis, to look for a blood clot, you can see that her transverse sinuses here, so superior sagittal, transverse, sigmoid, you can see on the transverse sinuses, she has these areas that look narrowed. Even though they're not blocked, they look narrowed. And this is not only consistent with high intracranial pressure, but it's also a potential treatment target. And that's actually why I wanted to share this case. We'll talk about how that can be a treatment target. So the next part of her workup here, she got a lumbar puncture. It showed high pressure, normal CSF, so no meningitis. And she was diagnosed with primary pseudotumor cerebri and started on acetazolamide, which is a carbonic anhydrase inhibitor. That's really the first-line medical treatment for pseudotumor cerebri. Unfortunately, she didn't really tolerate the medication, and so we had to start thinking about what other treatment options we would have. So for pseudotumor cerebri, weight loss is usually the cure. However, weight loss can take time, even for people who are really good at it, and of course can be very difficult in many cases. So we really have to focus on preserving the vision and getting the papilledema to go away while the patient is working on weight loss. Of course, weight loss and the best way to approach that and all the resources we have is really a whole talk in itself. So we won't focus on that, but that is obviously a key part in management here. So we have a few medications that can be used to treat pseudotumor cerebri, but in this case, we're worried because she has terrible papilledema. She's not responding to the first-line medication at a dose she can tolerate. And so we start thinking about whether there are surgical interventions that could help her. And so the three main surgical interventions that are good options in some cases of pseudotumor cerebri are an optic nerve sheath fenestration, which essentially involves going in and cutting a window in the optic nerve sheath to allow the fluid to egress. Some sort of shunting procedure, so like a ventriculoperitoneal shunt, where the brain fluid, the CSF, is shunted into the belly. Clearly that works to lower pressure, but it's quite invasive, and the patients end up with hardware that can cause problems either soon after the surgery or sometimes even years or decades later. Or our third surgical option, which is venous sinus stenting. And that's really the one I wanted to focus on for a couple minutes here before we move on to the next part of this presentation. So this is like a relatively new way we can treat these patients, which is why I think it's exciting. Hopkins has been doing this for about 10 years, but then there are a lot of places in the world that really still aren't offering this. So we have a lot to contribute in terms of this. So why would you stent a venous sinus? Well, theoretically, we know that venous sinus stenosis leads to an outflow obstruction and then high pressure proximal to the stenosis. And because of that, the CSF can't be resorbed through those arachnoid granulations at the rate it normally would be. Thus, the pressure goes up around the brain, and then the pressure goes up around the brain and it compresses the sinus more, and you get this feedback loop. And so, at least theoretically, treating a venous sinus stenosis can improve the high ICP. And in fact, intracranial pressure monitoring has shown that this is true. When you stent a sinus open, the intracranial pressure goes to normal. And so we decided that that would be a good thing to do in her case. Now, this is a good example of the way we have a multidisciplinary team approach with other departments. So one of our neurointerventionalists went in and took a look in the angio suite and again saw this stenosis here in the venous sinus. You can see the catheter going in there. And so at this point, he put in a pressure transducer to measure and make sure there was a venous hypertension proximal to that stenosis, and there was. And so then he deployed a stent, and you can see right after the stent was deployed that the venous sinus has returned to its normal shape. And even more impressively, you guys remember what her OCTs looked like beforehand. 3 weeks later, here's what she looked like. And then 5 months later, her papilledema has completely resolved. You can see that all this retinal nerve fiber layer is back in the green zone. In fact, maybe a little bit thin here, although that's probably more artifact. And her ganglion cells still look great, meaning that she kept excellent visual function and didn't have to be on medication for this anymore. All right, so that's the sort of thing I would do all day on Wednesday at my neuro-ophthalmology clinic. So on to the next day, which is Thursday. I have another academic day on Thursday, and I won't belabor this too much, but the other thing I love to do on my academic days is spend time on education. I have a clinical fellowship, so I direct that program and of course work with my fellow a lot in clinic and outside of clinic. And I love working with the medical students. Not only the Hopkins medical students, but we've had, students who come visit from other institutions and spend time with us as well. And so that's another thing I like to do in my academic time is really develop these education programs and work with all the wonderful medical students who are so enthusiastic and so fun to work with. All right, so I think we're going to round out the 5 days in the life of with one more neuro-ophthalmology clinic day, which is maybe my favorite day, which is Fridays, where I have a big neuro-ophthalmology clinic at the downtown Hopkins. So I was going to do another case. I think the other fun thing about my Friday clinic is I often have lots of learners, and so there are lots of interesting things to see And we're always open to having people come and visit. But okay, so I promised a kid. I promised we'd see a kid at some point during this presentation. So this is a kid, 6-year-old boy, came in with 1 year of declining vision. His parents, he's with his parents, and they say they've been taking him to a pediatric ophthalmologist and also to an optometrist, but his vision's not getting better. And in fact, it's getting worse, down to 2200 and 2080, worse than it was 3 months prior when he saw his pediatric ophthalmologist. And when we do his exam, when we look at his iris, we see these little growths on the iris. And he actually didn't have quite as many as in this photo here. He was a little wiggly to get a picture, but this is basically what he looked like. And when we looked at his optic nerves, they didn't look normal, especially not for a 6-year-old. It looks like this area here temporally is very pale. And so, we would expect the nerves to be very pink in a 6-year-old because they're young and they have lots of nerve fiber, but that was not the case here. And so we said, clearly there's something not good going on here. Not only does he have abnormal iris lesions, but he also has an optic neuropathy that's affecting his vision quite significantly. So the next step is to get an MRI. And so we did. And I circled the abnormality here. So you can see that his optic nerves are huge compared with what normal optic nerves look like. And so what this is, we have a young patient who has Lisch nodules on his iris, and then he has these infiltrated optic nerves, an optic nerve glioma. And so we were able to diagnose him with neurofibromatosis type 1, presenting with an optic pathway glioma that's causing vision loss. So the good news is, even though 20% of kids with NF1 have optic pathway gliomas, most of the optic pathway gliomas don't really cause a problem, and we can just watch them. And so usually that's what we do, but unfortunately this kid was losing vision. And so the plan was made to proceed with treatment. Just like the last case, we got the multidisciplinary team involved, and his team, of course, included oncology, neurology, and genetics, who not only confirmed the genetic mutation, but also got him connected with all the appropriate doctors to provide his lifetime care for his NF1. And for the optic pathway glioma, he underwent a course of chemotherapy and did actually have some visual improvement, though not all the way to normal. All right, and so in the interest of time, I'm going to go ahead and stop there and say, that's another kind of patient we would see. I think really my quick summary would be, neuro-ophthalmology is an interesting subspecialty in which we see a variety of patients with a variety of diseases. We're rare disease specialists and not specialists in one particular disease, which I think keeps it interesting. We have plenty of research opportunities, plenty of education opportunities, and I think we're a pretty fun bunch. You can see us all here last year at the North American Neuro-Ophthalmology Society meeting. And with that, I am open to discussion or questions or anything you guys want to talk about.
All right. Thank you so much, Dr. Henderson, for that awesome talk. We're going to go ahead and move into the formal Q&A part of this session with the time that we have left. The way we like to do this, since we have a bunch of us in the Zoom call tonight, is just with the raise hand feature. You can find it under the reactions tab on the bottom of your Zoom window there. If you click that button, it'll raise your hand. We'll see your name pop up, and then I'll call on you. You can go ahead and ask your question. So feel free to do that, and then we'll get to questions as they come in. Dr. Henderson, maybe just to kick off, one of our pre-submitted questions was, you touched on this a little bit, but I'll just kind of throw it to you again. You obviously have ended up in kind of an academic setting for neuro-ophthalmology. Are there other settings and kind of balances of that, week in the life that maybe trend a little more clinical or even a little more research heavy? Can you comment on what variety there is there?
Sure, that's a great question. I think neuro-ophthalmologists really can exist in any sort of practice environment. There are definitely private practice neuro-ophthalmologists if people are interested in private practice. I do think clearly in private practice, people tend to do more clinical work and less research and education work. And probably in private practice in general, neuro-ophthalmologists do more surgery than I do here. I'm not doing surgery, and it's just a choice of mine because there were too many things I wanted to do. But certainly neuro-ophthalmologists can do surgery, and many of them do. With regards to doing more research, of course, anyone who is research oriented really in any field can do as much research as they want, as long as they develop the grant support and the career to do that. I personally enjoy some of the clinical context, and I enjoy spending time with patients. I like the variety, but I think I wouldn't want to give that up. But certainly, there's any sort of breakdown is really a possibility, and there's someone around the country doing pretty much every combination you can imagine, including combining neuro-ophthalmology with other specialties, other subspecialties.
Thanks so much, Dr. Henderson. We'll pass it over to Sophie. You want to go ahead and ask your question?
Yeah. Hi, my name's Sophie. I'm an MS student from SUNY Downstate. I noticed that you showed some nice magnetic resonance imaging in your talk today, and I'm interested in both radiology and ophthalmology. So I was wondering what kind of role imaging plays in your practice.
That's an excellent question, and not one that I get very often. So neuro-ophthalmology is actually very imaging heavy. We're typically dealing with patients who either have a problem in their central nervous system, or in whom we think there could be a problem in their central nervous system. So it's actually very common in my practice for me to be the one who diagnoses, a tumor or an inflammation, like an MS kind of situation, or another autoimmune disease. This is very much in the realm of what we normally do. I think the other cool thing, if you're interested in ophthalmology and in imaging, is neuro-ophthalmologists, in fact, are considered to be responsible for interpreting their own imaging. Now, of course, a radiologist still looks at it, but I look at every single scan that every single one of my patients gets. And, in terms of sort of expectations and responsibility, neuro-ophthalmologists are considered to be responsible for looking at all of their own scans, which I think is a good thing, because it's a very cool skill that, that we develop largely in fellowship, that not a lot of people have. And just one more word on that, because I think it is important. Radiologists clearly are the experts on interpreting imaging overall, but we have this huge advantage because we've seen the patient and we've localized the lesion and we know exactly where it should be. And so I think that's really where a neuro-ophthalmologist evaluating a scan, and there's actually literature confirming this, that a neuro-ophthalmologist evaluating a scan can add a whole lot to the radiology evaluation, because radiology often doesn't have much history and they don't really know what they're looking for, and it's just not fair, but we do. And so we can really focus in on the area we're interested in.
Awesome. One question I just got sent to me in the chat for you, Dr. Henderson. You mentioned that there was quite a lot of work or availability in the future for developing new treatments for a lot of these diseases. Can you talk a little bit more about what you think, might change in the field in the next 10, 20 years or so? And do you see any big changes to the nature of neuro-ophthalmology coming down the line?
Sure, absolutely. I think there's a lot of work going on now in the areas of neuroprotection. So essentially, protecting from neurodegeneration even right after an injury, as well as in the areas of neuroregeneration, so things that fall in the realm of stem cell, and also in the area of gene therapy. So I think that those are sort of the three main areas that I would say, the most groundbreaking work is being done in these days. The timeline on those, I think is somewhat variable. I mean, we already do have some gene therapies that are FDA approved, right? And so, I think that that's certainly an area that will continue progressing in the next 10 years. Neuroregeneration and neuroprotection are having lots of exciting progress. When those things are going to be really applicable to neuro-ophthalmic patients in practice may still be a few decades out, but I think we're making progress in that direction.
Awesome. Jasmine, the floor is yours.
Thank you. My name is Jasmine. I'm a M3 from Penn State. My question is more geared toward how you are balancing your research and your clinic. As someone who's interested in pursuing research in my career, I find it hard to conceptualize what my role would be in a research project as a physician and trying to do like more basic science, maybe some model development, stuff like that. So I was just wondering how you or your colleagues, if you're not doing a lot of basic science type research.
Sure. Basic science, I'm really not a basic scientist by training. I've learned a lot from collaborating with basic scientists, but I do not claim to be a basic scientist, and I do not run my own lab. I do know lots of physicians who are MDs or MD PhDs at Hopkins who do run their own labs. I think this is the sort of thing that if you want to be a clinician scientist in your career, you have to start early with setting aside time to do research. And this may involve things like K awards to support your research time as a young faculty member. At Hopkins, we have a really unique program which has been developed by our chair and some very generous donors to support young physician scientists or young clinician scientists called a rising professorship. So assistant professors can get like a professorship to help cover their research time. You're absolutely right, though, that running a lab takes a lot of time. So if that's something you want to do, I think what I know from my colleagues is that you do have to set aside a significant amount of time to do that. Did that answer your question, or is there a specific area I could answer better?
No, that was fine. I was just I think comes down to it's so individualized is how people balance the two. I was just asking for your perspective, and I think you've answered my question. Thank you.
One other of our pre-submitted questions. What other medical specialties do you interact with and intersect with in your career? And what does that look like? Is that, referrals back and forth, or are you having direct conversations about patients and planning and co-managing? Can you just say more about those collaborations?
Absolutely. If I didn't already say it in my presentation, which I think I did, I actually love collaborating with other departments. I think it's really fun, and you learn new things every day. And you can work with a group of people, each of whom has one really important piece of information to bring to the table, and working all together, I feel like we can really give patients the best care. I would say I co-manage with other specialties outside of ophthalmology every day to some degree. Either I talk to people on the phone, or the Epic message system has made it really easy to sort of talk back and forth, not even if you're busy during the day, and certainly by email, as well as in multidisciplinary meetings. So we have regular meetings at Pituitary Center, for example, where we all meet. It's neuro-ophthalmology and radiation oncology and endocrinology and neurosurgery all meet to talk about all of our pituitary patients that have been sort of complicated that few weeks or whatever. So I think the collaboration is very very direct. I think it's much more than just referrals. It's direct communication. And in addition to those groups I just mentioned, we collaborate a lot with oncology, with neurology for management of all the neuroimmunology patients, and interestingly pulmonology, mainly because they have a tendency to prescribe some toxic drugs that we help them deal with.
Awesome. Josephine, do you want to go ahead?
Sure. Hi, Dr. Henderson. Thank you for talking to us today. I'm Josephine. I'm a second year at Medical College of Georgia. I was wondering how often you get urgent cases. You mentioned that you had to get an urgent MRI on one of your patients. Is that something that you have to do very often in neuro-ophthalmology?
Yes, absolutely. I think, rarely do the interesting and important cases wait 6 months to see you, I think the people who really need you pretty quickly. So we do get a lot of urgent cases. And fortunately, we've come up with a way to sort of manage that so that we can accommodate the urgent cases when we need to see them. So yeah, if you like, taking care of people when they need it most, I think it's neuro-ophthalmology does get a lot of urgent cases.
And one other thing, guys, if you're not able to come over on the speaker and talk, feel free to just post your questions in the chat too. We can read them out as well. Dr. Henderson, one of our kind of general questions we like to throw at a lot of our speakers is just what advice do you have, for students that you feel like maybe they don't ask about, or that you wish you had known before you even decided exploring ophthalmology, and then even further down the road, identifying neuro-ophthalmology? Is there any specific advice you'd give to students who are maybe still thinking generally about the field?
Well, that's a good question. I always wonder if I'm really qualified to give anyone advice, but I would say, the one thing, I guess this is fairly general, but if you're early in your career or even approaching your mid-career, I think saying yes to as many opportunities as you can, if you're not sure exactly where you're headed, can be really helpful, because even if you think you have a pretty clear idea of where your career is headed, sometimes you get a cool opportunity and you don't want to miss out on that. So I think if you're keeping your options open, that's great. But then make sure to take advantage of any opportunity that comes your way to learn more about ophthalmology or more about any other subspecialty. Get involved in the research project, or stay late to go to the OR and see what's going on. I think you'll never be sorry that you did those things.
I just got a very good and timely and topical question in the chat. How do you consider the usefulness of artificial intelligence in neuro-ophthalmology to your understanding? And, how do you think that's going to affect neuro-ophthalmology compared to some other specialties, where it's commonly talked about as well?
So I think some version of this question has come up in every venue I've talked about my research, or anyone's research, in the last month, including sort of huge varieties of people. So this seems to be a real area of interest for everyone on the planet right now. So certainly there are lots of implications or lots of potential uses for AI in neuro-ophthalmology. I do not claim to be an AI expert in any way, so I will caveat my answer with that. We are starting to use a little AI in some of our research, largely because the statisticians who work with us are using AI to develop some of the models now. So some of our research is using some of that AI to develop models and to develop clinical decision support models. So I think that's sort of a way that we're starting to use it that most people don't even think about. Perhaps on the more glitzy side of AI, we all know that AI can look at fundus photographs and identify diabetic retinopathy. But what we don't all know, and what is pertinent to neuro-ophthalmology, or maybe you all know it, but I doubt it, is that there is a big neuro-ophthalmology consortium which is called Bonsai, which I am not an affiliate of, but I know many people who are who have developed an AI that actually can identify why an optic nerve is swollen. And so one finding they presented recently is that it can tell whether an optic nerve is swollen from giant cell arteritis or not. And, the implications of that sort of diagnostic capability are huge. We sit around and debate when we would want to do temporal artery biopsies, but if we have an AI that can tell us whether a patient has GCA, I mean, the implications of that, it changes the way we practice. So that's not yet FDA approved, so not yet in clinical practice, but I think these sorts of applications of AI could really change the whole field of neuro-ophthalmology.
Awesome. Thank you so much for talking about that. It definitely is, the buzzword of 2023. So it's cool to hear about. Any last questions from anybody in the Zoom call or in the chat? We've got a few minutes left that we can answer some if we have time. I will round out then with just one more from our pre-submitted ones, kind of touching on the topic of research specifically. For medical students, specifically within medical school and kind of getting ready for residency, what kind of projects or opportunities within neuro-ophthalmology do you think are the best for getting a sense of the field and, kind of putting together your application as you look forward to applying to residency as well?
This is always a popular question as well. I think there are many opportunities for sort of contributing to the literature or dissemination of information, if you will. Clearly, taking on a big research project that you're going to do as a medical student can really help boost your application and can give you great experience. But if your goal is to really find out what a field is like, I'm not sure that really gets you there. So it's sort of two separate questions, I think. I do think in terms of disseminating information and also learning about neuro-ophthalmology, one thing I recommend to a lot of my students, and I've probably had, 25 people or 25 instances where this has worked out, is that my students take a topic and make a learning object for our Nanos Illustrated curriculum, which is a curriculum that's put together by colleagues and I at Nanos and is our fellowship curriculum. And I think actually by putting together a learning object, the student can learn a lot about a neuro-ophthalmology topic, sort of become an expert on this and get a peer-reviewed publication. Now, is it technically research? Of course not. But I think it actually gives someone a better idea of what neuro-ophthalmology actually is and what kind of things we do than, say, doing a chart review would. Of course, both of these things are important. And if you're thinking about building an application for ophthalmology, I think everyone wants to have at least some research project on there. And clearly, if you have a goal of being a clinician scientist in the future, then you want to get involved in more involved projects, if you will, and learn some of the analysis yourself and contribute in that way. I'm not sure that was a great answer, but I guess the bottom line is it depends on what your goal is with that particular project.
Definitely. It's helpful to hear your perspective on that. I think to be respectful for everyone's time this evening, we'll probably wrap up our Q&A portion there. So Dr. Henderson, thank you so much for your very thoughtful answers. I will pass it back over to Kayla for just some final notes.
Sorry about that. Alrighty, so thank you all for coming. Again, you can find this recording on our website when we get that up. And just overall, yeah, this was a wonderful session. That was a great talk, Dr. Henderson. And I really did appreciate the advice that you gave at the end about research. I hadn't considered making kind of learning points, and for educational materials, that's a really good idea. All right, so if you guys don't have any other questions, you are free to go.